Antes de empezar con la mesa que tenemos hoy por la mañana, nos gustaría compartir con ustedes algunos resultados de nuestra conferencia del doctor José Manuel Freire de ayer. Tuvimos 1.830 visualizaciones de
1,830 visitors from 4 continents. We covered all the South American countries, 27 countries throughout the world, including Japan, in Africa and Europe. This was our record of hits in our online conferences, and people thanked us, APS from the University of Colombia, coordinated by Dr. Guerrero, the University of Porto, of PAHO, of the Latin American Association of Social Medicine, ALAMES. Also, we received an email from the former Minister of Bolivia, Dr. Lamira Heredia. She thanks us and said that from this conference, she proposed 3 debates on APS using the inputs of the conference, and this conference also, and the debate that follow will be available in our website and in YouTube, so you will be able to see it and use it in your classes, discussions in your own countries. That is why we thank you. We thank for the presence of our speaker that gave us an excellent presentation, not only for us that we are here, but for over 1,800 people from 27 different countries around the world. Thank you very much, Dr. José Manuel Freire. Now, I would also like to provide the representative of the countries. This list is about the Friday meeting that we have on Universal Health Groups. We know that not all of you will participate for technical reasons, and we know that consultants and people that came from the workshop won't attend the meeting, but for the rest of the people, so we can organize the meeting on Friday next. So please, you indicate if you're going to participate or not. Now, yes. Now, we are once again to turn off your cell phones, so there won't be any problem with the panel. And we will continue with our workshop on the primary healthcare approaches and strategies to retain health workers in remote and underserved areas in South America. This is being recorded, and we will make the presentations available. We will have some primary healthcare approaches in South America, models of primary healthcare in South America. This refers to a mapping work. This is a produce of the ISACs corresponding to 2013, and this version is the continuation of the mapping work involving 6 consultants from several countries who are researching 12 South American countries. The panel, we have a coordinator and 6 panelists. They will have 20 minutes each for their presentation, and after the comments of the coordinator, we will have a 1-hour debate, question and answer session. From the Sergio Arouca National Health School, Dr. Alicia Giovanella will be our coordinator, will coordinate the panel. She's a physician with a master's degree and postdoctorate studies, Frankfurt University, and the University of Applied Sciences in the Department of Nursing and Health Sciences. She coordinated the network on research and systems in the South Camp from 2005 to 2009. She's got experience in compared perspective healthcare and primary attention in health. She's consultant of the ISAC since its inception. She was one of the organizers of our system of health in South America and coordinator of mapping models for South America. Now with you, Dr. Alicia. Good morning to you all. Our panel will be made up of, we will have the presentation today of the results, partial results of the primary healthcare mapping in 12 countries in South America with our consultants. For a question of space, we are going to present our consultants, and then I am going to introduce each one of the consultants. The preparation of mapping of primary health care in South America by the ISAC, as established in the operational plan approved by the Council of Ministers of Health in UNASUR, aims to provide knowledge and expertise on the conception, models, and experiences and challenges also in primary health care in the South American countries, and to contribute so that governments may identify policies and strategies to have local or regional intervention in order to build universal public health systems and the guarantee of the right to health. Since the Declaration of Almeida on primary health care in 1978, as we said yesterday, there are some tensions among different manners of addressing in the implementation of health care in South America countries. The Almeida Declaration has a conception of primary health care and interprets as a part of this system, of the health system and of the economic and social development of a country, involving cooperation with other sectors in order to face social determinants of health. These principles will vary according to the systems of social protection and health system in each country, and the historical and social processes in each country, and has presented in South America different emphasis. In South America, for example, in the authoritarian context and macroeconomic modifications, primary health care adopted models which were selective and focusing, which were promoted by multilateral agencies, trying to reduce the role of the public sector and implementation of minimum packages of health care for certain marginalized groups. They were also addressing specific health problems with the creation of certain insurance, and this deepened segmentation in the years 2000 with the new democratization of our countries. Primary health care is revitalized. As said in Almeida, the building of health systems guided by integral healthcare, coordinating a network of services and actions, intersectoral actions in that address the social determinants and guarantee universal rights. In South America, there are several processes of reforming the healthcare system, expanding access, and with innovative movements in the organization and practices. with features of integral attention or healthcare. In this regard, the UNASUR Council proposed a mapping of this primary healthcare approach. The mapping work was carried out by consultants, specialists in topics of primary healthcare in the countries. With the support of national representatives of the work group of UNASUR in Universal System, visits were organized to countries, visits to the ministries, and data compilation, and also of experiences and services selected by the Ministries of Health from November 2013 to April 2014. With all this documentation, information, and interviews, and revision of literature, consultant made case studies by countries. And they are revising these case studies that will give rise to a comparative study on the countries of the region. With the products of this mapping and the discussions of this workshop, we will organize an Isaac's book on primary health care in South America. 5 consultants were selected, distributed by region. Region 1 with Félix de Almeida of the Fluminense University. Region 2, Argentina, Paraguay, and Uruguay with Gilberto, Rios. And Region 3, Bolivia, Ecuador, and Venezuela with Tejerina Silva from Bolivia. Region 4, Chile, Colombia, Peru with Naydú, Acosta, and Mr. Andriga. And Region 5, Guyana and Suriname with Mrs. Guch. Mapping were carried out on the basis of a matrix organized in the dimensions that you see in your folders. The main dimensions were financing, characteristics of the organization, servicing, coordination of care, integration of in the network, labor force, inequalities in access, participation, social involvement, activities, intersectoral activities, and interculturality. The presentation are instructions in some of the dimensions comparatively among the regional countries in an effort to make a summary. This is our first experience. The case studies are being now concluded. That is why we didn't distribute. And this is the first attempt to make a presentation. So we have to present 4 countries in 30 minutes. Thank you very much for your efforts. It is important to explain that the idea of comparison is not to establish a measure, better or not, more or less, but to analyze and understand the challenges to implement primary health care in our countries. I understand that the current configuration of health systems and primary assistance is conditioned by the history, by the situation in terms of politics and economics, and the performance of the health systems with the rates and more or less are not appropriate to analyze the situations. Researchers today, there are a certain consensus on the insufficiency of classification of health systems, and that we have to see them with being skeptical with them. The comparative work will provide a summarized view of the situation in South America, ordered by information given the country's knowledge on primary health care. In order to compare experiences, it is possible to identify and understand shared problems and to know the possibilities and solutions in each country that can also be used in other regional or national policies. Thank you very much again to the presenters for their work and their efforts and endeavors and their summaries, and they have 20 minutes to present their work. So let's start with Region 1, Brazil, to be presented by our consultant, Peti Fidelis de Almeida. She's a psychologist with a doctorate in public health care by the Fundación Osvaldo Cruz. And she's also a lecturer at the Department of Health at the Federal Fluminense University in Rio de Janeiro. And she's a researcher in the area of policies, evaluation programs, and primary health care. And she's the coordinator of a research work financed by the Technological Council in Brazil on primary health care and the coordination of healthcare in the state of Bahia, and also participated as coordinator of the National Improvement and Access to Quality Program and Basic Care as a coordinator in the city of Rio de Janeiro. You have the floor, Dr. Betty. Bom dias. My mission is easier than that of my colleagues because I'm going to present one case, which is the case of Brazil. The SUS system in Brazil is a service, it's a national service of universal access and funded by the state, which is based on three principles: guarantee of the right to health, which is an obligation of the state, decentralization for states and districts, and also the involvement of citizens and the guarantee of integral health care. We have 194 million Brazilians that have the right to health guaranteed by the Constitution. However, we have more or less 1/4 of the population, around 25%, that has a double coverage. That means to say they have access to the SUS, but also they have coverage. They have a private health program. It's a direct purchase that they, or even the employer provides it. We also have health centers since the 20th century, but in 1994 we started a process of reform of primary health care through the strategy called Family Health in 1994. The strategy is increases in 1998 due to the tax incentive that are transferred to the municipalities. We have a relevant and important broadening of the access to basic services, and today we have almost 35,000 family teams that provide health care to 6 million people. But we also need to emphasize that there are other models of primary health care that coexist for 94 million people because they have access to other forms of primary health care guaranteed by health centers with basic specialties, pediatric, general physicians, nursing, and so on. In order to have an idea, we have 258,000 community agents in the area of health, 34,000 teams covering 60% of the population, plus dentistry teams that form part of the strategy, family health care. Our primary attention or healthcare system has a set of actions, individual actions, collective actions too, including promotion, protection, prevention, diagnosis, treatment, and also reduction of damage and maintenance of health, and also the capacity to get involved in social determinants of health. Our conception that appears in the national policy of basic healthcare follows the principles of the concept of health in the 88 Constitution, and our policy affirms that the strategy of health of the family is the main strategy to reorganize primary health care. But not only that, but the model of health care. So we have an increment of teams regarding the model itself.
In detriment of the other models that we call them actually the traditional models in primary health care. Well, our whole official concept is guided by some attributes, actually, which have the attribute of accessibility, door of entry, preference, link, responsibility, public health responsibility, coordination, continuity, and participation, citizens' participation. Still, these attributes in time do have different degrees of development. We observe, for example, that there's a low development at intersectorial level in order to approach the social health determining factors. Also, there are difficulties in order to link actually informations on the territory related information to clinical care. Still, information collected by community health agents lag behind, even though their organizational barriers on the organization of the working process, basically based on programs, are lagging behind too. This represents still an important barrier to access to primary health care systems, since we have 5,550 municipalities that do the organization of primary health care. We also have the development of different minimum standards in terms of good quality. On financing now of primary health care, we have financing actually tripartite financing. We have states and the the municipalities, the state, and the federal government. As we saw yesterday, national public expenditures is low, 3.67% of GDP. Public expenditures in health, in the total of health expenditures with data of 2011, represent 46%. If we are to see there is an increase in funds, federal funds, in order to be invested in health in the last decade, close to 67% of expenditures for the ministers is dedicated to health. Out of the some 35 of the expenditures with the ministry's health care, the expenditures are for primary health care and 65% for specialized care and also hospital care. We have several mechanisms in order to transfer federal resources, some per capita based, that receive all municipalities received to organize their primary health care. It is another type of transfers, which are resources linked to the development of different projects, specific projects. For example, which is one of family health projects, street doctors' offices, the different units for the populace that live by the river banks. And lately, we have a project from the Ministry of Health for also regarding the quality assessment of primary health care. Now, it's a new innovation. We have a national program in order to do the assessment of the improvement of access and quality of primary health care services. And depending on the outcome, the teams can have access to additional resources. There is no co-payments for primary health care. We don't still have the full provision of drugs. This is in terms of organization. As was said yesterday, we do have 5,570 municipalities that are independent in terms of their organization of the primary health care. Now, the door of entry is defined in our policy, which is the first level of care, but also we recognize that there are other types of services. For example, urgency or emergency services like a door of entry, but not a preferential one, and also we have psychosocial services. Still, we do have problems in lack of access. In the study, the Ligia quoted in Brasilia, on 37% of the population actually seek emergency services in case of diseases, even though the health units, the family health units are still open. They go to emergency services. We do have primary health care, which is provided in 38,000 basic health units. Those are health centers, family health centers are units, and also that in general operate from 8 to 5. But there are changes also in Rio, for example, in other cities. There are extended working hours. We want to work also on Saturdays in order to be able to increase access to the population. Primary health care units are public and work at municipal level. Our family health team, we do have the doctor, the GP. Actually, most of those are not don't have a resident in the residency, but they are general doctors. We have an orderly, who is actually is a professional. We have a technician, and 4 or 5 actually we have health community agents. Those are people that live in the community where the family health strategy is implemented, and they are not trained in health. Each health team has an area with 3,000 people approximately. This varies according to the density of the population of the area. The risks involved. The territory is defined according to different criteria, populational criteria, for example, but also we do consider the vulnerability or different epidemiological aspects, amongst others too. One of the most important things for us for the provision of services is the shortage of doctors in the country, especially in the inner land, in the north rural areas. That also we have difficulties in order to fix doctors in big cities like Rio de Janeiro, in the most peripheric areas. Well, one of the problems that we have is the more doctors program from Brazil will be introduced in the coming discussions, just to have an idea. So we have 1.9 doctors per 1,000 inhabitants, with a distribution which actually varies according the different regions, where the lowest concentration can be found in the north of the Amazon region. We cannot state what are the contracting formats, because we have different contracting formats from the different municipalities that go to public contests, and they have these teams. They have job stability, and working contracts. Also, they're very flexible to contracts that for a certain time, for the transitory provisional contracts for a certain period of time, or contracts in which the municipalities transfer funds to NGOs or different foundation, different neighbors associations to hire the necessary professionals. Recently, in some municipalities, like this is the case of Rio de Janeiro, also management has been handed down to social organizations, the provision and direct management of services. It's very hard. Having an average wage depends on the municipality. It depends also on the contract. On coordination of care, we're discussing integration primary health care within the framework of health regions. Brazil has 436 health regions. Now we are discussing the setting up of different networks. This region wants to provide timely care in order to resolve health issues. Primary health care should be the communicating link for this network, but still the function of the primary health care doctor is not regulated. But also we need to have this type of reference. There is no policy established yet in order to ensure minimum and maximum time frames for this primary health care, and the networks are not fully developed, which is actually a barrier to coordination. In regional inequalities, actually we have also social indicators, different social indicators, like the Northeast region. We have the highest family health care coverage in the country. There are studies that show also the reduction of mortality rate, child mortality rate, increasing coverage in family care. And also we find synergic effects in reduction on mortality rate when we work with family health, and also we work together with cash transfers. Well, the different intersectorial activities is a critical point for us too. It has not been fully developed in primary health care. We also actually have certain initiatives. We have the health academies that function together with the different basic health units. These programs have funds, federal funds, and actually it is voluntarily based. One or third or half of the professionals actually develop actions to resolve health problems in the community. Then when participation happens through the different health councils that are included in every municipality, we also have the different health conferences that are held in every 4 years, and the regional or local health councils also that we have in 59% of our teams. Now, to end up, we like to tell you about two experiences. One in terms of reorganization of access, and experience in terms of reduction of, another one, reduction in terms of barriers to access. We have in Iguaraçu, which is the first unit, the first actually boat, which is a health unit, attends the riverbank population of the region of the Amazon. Also, they're working also differently, of course. They spend 20 days within the within the communities that live by the riverbanks. Then they come back, and they go back to work through in the river. And it's a very interesting experience. Actually, the maintenance costs are very high, and the cash transfers are not sufficient. And this here we have a photograph, as you can see actually on the screen. It's beautiful. It's the best part of the mapping process, as you might imagine. Yes, we were there. It was great. We had a great time. And another experience also, because we have a municipality located south of the country with a very highly qualified primary health care system before family health care, but it has a 100% coverage of the population. But now we are discussing the working process, and it is a very difficult discussion. Actually, have Curitiba. They were working within the vertical programs, and the population had no more access to primary health care services. They had also a diagnosis of 30% of the population that want emergency services. This is something also which is an expedient that is very interesting to note. Well, now to finish my presentation, we have a few observations. The regionalized networks are being established, their frailties, weaknesses in regional strategies, the strong dependence on the private sector for the provision of a specialized care, especially in diagnostics. There's a low participation and also intersectorial development, under financing of health. We do have advancements in the definition of quality standards for primary health care, and national evaluation processes are underway too. Also, very big investments are made in units for primary health care units, and also actions are endeavored to increase teleconsultancy. We have programs in that sense, and also more doctors program also for Brazil. Thank you very much. End of presentation. Thank you very much, Betty, for your speech. Now let's go to the presentation that will be made by Region 2, Uruguay, Paraguay, and Argentina, with our advisor Gilberto Rio. Gilberto Rio has been coordinator of the working subgroup number 11, Mercosur, from 2005 to 2011. He has been national coordinator of the Council of South American Health from 2009 till 2011, representing Uruguay. He was general director of health for the Ministry of Public Health of Uruguay from 2010 to 2011, and currently he is chief investigator for the profile of health in Uruguay within the Mercosur Observatory of Health Systems, and now he is academic deputy of the School of Medicine and the University of the República, and he is president of the Uruguayan Society of Collective Health. Gilberto will have to make a bigger effort because to be introducing he will be presenting the three countries together in only 20 minutes. The case studies of the different countries are all have been completed, and they're being reviewed. We have read and we discussed them, and they're being reviewed by our advisors. So, Gilberto has the floor now to do the presentation. Good morning to all of you. Effectively, it's a great effort trying to synthesize everything that has been written, has been said in the different countries, and the wealth represented by the visits that were made to the three countries in order to advance in the mapping process. We're going to be very synthetic. Then in the Q&A session, perhaps we will be able to elaborate more on these topics. But the first thing that I think that's also very important, for just to have a basic idea of the realities of the country, is that we need to have an idea of what is the system that we exist in each one of the countries in general terms. We have Argentina, that has a public system based on the Ministry of Health, which is a system based on social security system, which are called obras sociales, the private system, the prepaid system. Among these three, provide coverage of 100% of the population, with substantial differences between them. The private sector, 35% of the population, then 45% pobreza social is what they call, and prepaid coverage by itself represents 5%, and prepaid through obras sociales 11%. Beyond the coverage also, with a segmentation. Let's say the health services in Argentina are segmented. On the other hand, in the case of Paraguay, the situation is more or less similar. It's a public system in which, on the one hand, we have as a centralized administration, and the Ministry of Health is a service provider, together also with police and military services. And also we have the Hospital de Clínicas and the Social Security Hospital, which is the body that ensures the population in Paraguay and has a coverage of 16%, and naturally informal workers. Then there's a private system where we can find NGOs and also different, for example, prepaid in medicine and private providers. In mixed units, we have the Red Cross that has contribution from a private foundation and from the state. You have to see also there is a segmentation in terms of care.
And perhaps what called the attention, as we see it, is the low coverage in Paraguay, which is 16%. In the case of Uruguay, the situation, we have an integrated health system with the two sectors, public and private. And the public sector, there is a coverage of 46% plus policy, healthcare, and the clinic hospital, and the funds. And we have also the service of state with 34% coverage, which is the most important provider of services in the country. Also, we have a private sector, which is made up of or covers institutions of collective medical care, which are a reconfiguration of the old institutions in the second half of the 19th century. And we also have other organizations, medical cooperatives, which are regulated by the state and governed by the state, covering 57%. And then we have the private sectors, the private insurance that cover in 2011 3% of the population. Regarding these services in all these countries, since the second half of 2000, there were substantial changes as countries, particularly these changes also in the organization of the medical system. The theoretical basis of the three countries are common ones, and they coincide with some aspects, and the concept, the most important thing that they has to do with the integral healthcare system, accessibility, and trying to cover all the population and not fucking PHC, children and mothers, but for example, all the adults, chronic diseases, adolescents, and so on. That means to say all the society. The legal basis for the strategy are also different among the countries. In general, these are decrees, some acts or legislation, a resolution of the ministry. In general, they are not acts. In the case of Paraguay, there is a strategy very with a profile since 2008, and the basis of the development in Paraguay. The legal support is a ministerial resolution For example, they are very important and have legal value in order for sustainability and continuity of the policies. In the case of the Constitution, except in the case of the Argentinian Constitution, there is no term that refers to PHC. In the case of Uruguay, there is a law that creates the whole system, and also in the Federal Plan of Health in Argentina, and there are many PHC concepts that, but there is no general rule establishing a strong legal basis. In the case of the development of the strategy in these three countries, we visualize what they do at the first level of healthcare, beyond the involvement of PHC, because in the mapping we left it very clear the structure of the PHC, but PHC is far more than the structure. That means it covers all the aspects regarding integrality, continuity of attention, and in the three countries what we can see is what they are doing at the first level of attention to the public. In this regard, integrality of attentions cannot be guaranteed with the initial description of fragmentation. You will see that many services have to be bought abroad. And as I said before, in the three countries, there are substantial changes as country and particularly in the health component. As regards the PHC organization, depends on the political organization of the countries. In the case of Paraguay and Uruguay, which are unitary countries, most competencies and duties are in the Ministry of Health, although the municipalities and districts have some duties also. In the Argentine, which is a federal country, the competencies and duties are delegated to the provinces and to the districts, and also the Ministry of Health. And therefore, we may say that the national ministers are in charge of implementing that, and the weight, what is pushing all this in the three countries, is the public sector. As regards funding and financing of PHC, both in the Argentine and Paraguay, the preponderant role of the ministries, that means to say, is that the funding comes through taxes. In the case of Uruguay, we have two sources: the national health insurance through the FONASA, with a contribution of Social Security, and also from general taxes for funding the public sector. In the three countries, the public sectors, there is no co-payment for PHC. This is not an unimportant date. In Paraguay, there was some co-payment scheme. And in the private sector, there are variations among the country. There are some from mandatory exonerations and discretionality to determine the prices. In none of the three countries have a specific budget for PHC. The most approximate that we may think of, which is the budgeting of the first level of healthcare. Paraguay has a specific budget for the development of strategies. They have all the structures, regional coordinations, human resources, and so on. They have a budget for that. But if we see primary attention and integral, we have to add up what the district hospital does when the patients go. That means to say studies, clinics, drugs, and also specialized attention. And also, it is very difficult in the country to have an idea and start adding up other funding sources. For example, the cost of basic sanitation, drinking water costs, and so on. That means to say intersectoriality doesn't allow us to have this accumulated data to see how much these countries are investing in order to carry out their PHC strategy. And regarding transfer mechanisms, in the cases depending from general taxes, in all the countries, we have the initiative of the executive approval by the Assembly of the Congress, and in the case of Paraguay, it's implemented through the Primary Attention Directorate, or also the obligation is transferred to the provinces. Also in Uruguay, we have the minister which finances everything, and also then the districts. In the case of funding of social services, in Uruguay, the payment is adjusted according to the RICS plus assistential figures. And also in Argentina, we have the PAMI, which is the structure that provides attention to pensioners. These institutions have the obligation to implement the program, the minimum program, and there is a payment per individual. In the case of Paraguay, IPS, the contribution of the worker, the formal worker, also includes with the right to attention or health care in the services. Which are the main features of the organization and PHC servicing? It is very difficult to make a summary of these units, but basically, I would say that in the Argentina we have the centers of primary attention, in Paraguay the family centers, and in Uruguay the health centers too. In each three countries, this has there are other structures that apply in the clinics and medical offices. In general, it's predominantly public, and in some cases with private involvement. They do it with the with system, which is the predominant paradigm, which is very centralized. The teams that identify those who participate in the services are not the same in all the countries, but it's a standard of physicians, gynecologists, auxiliary staff, nurses, dentists, and so on. The variation with the availability of human resources in each country, we may find that, for example, we may have instrument, or you go to Paraguay and they have a doctor and a nurse and a community agent, and difficult accessibility in the region in Paraguay. As an entrance door, this is a theoretical definition. None of the three countries can have just one entrance door to the system. The hospital is the most attractive one. People go there, and as the hospital resolves the problem, they can also achieve access to other services through the hospital. Teamwork. There are systematic effort, but the results are not homogeneous. This is not the same for all countries. These disciplines that work together, we may not say that it's a team, but there is an effort, an endeavor, an intention to do things well. In the case of Paraguay, we have 3,000 to 5,000 for each basic health team. In the case of the Argentina, 3,200 and 4,000. And in Uruguay, there is a target that the doctor has to implement. They will try to have some sort of definition in terms of numbers in Uruguay. In Uruguay. The services that are common to all these countries are the consultation on demand, control of the mother to the child, family planning, vaccinations, promotion of education. They work with the educational sector and neighborhood organizations. The difference factor. These are the common. The differential factor has to do with the organization of the system. When more integrated or more fragmented, they allow the access to other type of services, geographical distribution of resources, funding of the system, availability of human resources, decentralization of the system, and political positional of the PHC and local player governors, mayors, and health organizers. This was very useful to understand the reality, how in the territory the political factor has an important role to be able to incorporate other tools to the services. There are other actions that may appear, for example, attention, dentistry, rehabilitation, diagnosis by images and in laboratories. Everything is conditioned to the differences of the political issues, and also it is not the same the more metropolitan and capital areas that the further areas that don't have access to human resources, or geographical accessibility is sometimes very difficult. Even if they wish, they cannot have all these different actions everywhere. As regards the coordination of the services, in all the countries, this system is organized by levels. Although we have the first level, the second level at the hospital, the PHC physician is like a filter. He wants to be a filter. And derivation of specialized attention is conditioned by interpersonal relationship. You know, the doctor, so he may send you to a hospital and so on. But in general, the reference works well in the three countries. It has now the counter reference. For example, there are some problems in the three countries that the counter reference in writing doesn't arrive, informing the doctor what is the procedure which was done, that he has to take a certain procedure. On the waiting time for the patients, there is a waiting time, but this time sometimes it's not known. In the case of Uruguay now, they are using it so that people once a year can change the services, taking in consideration to choose those in which they have to wait list. Regarding the labor force, there are many ways, but in general there are renewable contracts according to the performance. It could be also included in the budget, and remunerations are salaries, are in the form of salaries. And on top of that, some prizes, some bonuses in order to eradicate or in order to have professionals in very specific areas. It is very difficult. We have data for the state countries regarding the availability of human resources. There is a substantial difference between Argentina and Uruguay in relation to Paraguay. And then we see the composition of the basic health teams. So where we see the differences. In the case of nursing, there is a deficit in the three countries. And we have an auxiliary nursing assistant. And we have also community agents working of nurses. As regards the qualification strategies, we have a community doctors program in the case of Uruguay and Paraguay. The universities, they have family and community courses, and also in Uruguay, family and community qualification for doctors. In the three countries, they try to use doctors or physicians in primary attention and also in nursing and also in nursing. The regional inequalities and social inequalities are a clear element. There are three concrete data. Uruguay, physician, 75% of the metropolitan areas. In Paraguay, In capital and central region, 50% of the physicians. In the Argentine, in the city of Buenos Aires, we have 100 doctors and one doctor per 100 people, and in the northern of the country, much less. We have intersectional activities in the countries. It is traditional, the relationship with the educational sector. There are some innovative experiences. Also, we have social involvement, which is an identity of the process. Formal involvement spaces have been broadened, and they legitimize the strategy. The interculturality in PHC in Paraguay, there are some examples. They are incorporated the strategy knowledge in the Argentina. In the program of the community doctor, they have an area for indigenous health. Innovative components, to say very concretely, now to mention in the case of the Argentine, the community doctors with a strategy of qualification is valid the same as in network hospitals. In Paraguay, we have the development of the strategy, and Uruguay, payment by services, incorporating the attention to the woman, which was one of the solutions to guide the system through the PHC model. On the final considerations, there is a new push for the PHC in the region. The leader is the ministry. There is no exclusive funding covering from physiognomy for the development of the first level of attention. There is a basic matrix, and also there is a network with a reference to a second level, and there is a difference in the reference account and economic inequalities.
That condition the strategy, and there is a form trading of human resources with different types of strategies. Even also has motivated for the flexibilization of human resources regulation by the ministries are actually to be able to cater the needs of rural populations. Also to incentivate eradication, actually diseases in rural areas, social participation is very important. And the more common factor is the difficulty to integrate the private sector. In the sector that does coverage, social security, the one that is closer and has more possibilities to work together. Thank you very much, Gilberto, for your excellent presentation and synthetic effort. And now we're going to go directly to our region number 3 in Ecuador, Venezuela, and Bolivia with our advisor, Herland Tejerina, who is doctor in public health, graduated from the Catholic University of Valle. He has a master's degree from the Institute of Tropical
15 minutes.
In the International Pan-American Health Organization, and who is his independent advisor. He is a professor, titular professor of the private Universidad del Valle in Bogota, Bolivia, and also now he is our advisor. Herland has the floor, and he has 20 minutes for his presentation. Thank you very much. He says it's a pleasure, it's an honor, and a challenge, having tried to give an opinion and analyze the complexity of these 3 countries in such a short notice, and introduce to you in very few 20 minutes all of this together. The first thing I would like to say, please don't expect to be able to understand the complexity of the 3 countries with my brief presentation. I'm just going to try very simply to draw some elements, common elements, and try to respond to some characteristics, different characteristics that I consider them to be as the most important of all among the 3 countries. The first thing that has to be stated is the 3 countries do have actually transitional systems, provisional system from the assistential model created in the 20th century, focused on actually in urban hospitals, and also marked by the by the reduction of financing, decentralization, implementation, or deepening of out-of-the-pocket payments, and something which is vital that has to be understood, which was a strong orientation towards selective primary care. Actually, the three countries at least were strongly marked or influenced through the 90s by this new idea. First, the left back segmentation in the three countries between social security systems. In Bolivia, actually covers 35%, in Ecuador 23%, in Venezuela around 39% of the population. Then the selective insurance in Bolivia covered around 12% of the whole population, and private insurance that in Venezuela cover 20%. And fragmentation, which is a fragmentation also, which is very, very strong, understood at different parts of the system that do not work coordinatedly amongst themselves. Also, it's common to find amongst the three countries actually the turn the governments made from the end of the 90s and the first decade of the years 2000. The three countries have socialistic governments. They self-call themselves as being socialistic. In the three cases, they have approved new constitutions, political constitutions. What is the commonality? They had to identify health as a right, and the state should be its guarantor. That identify new health models. In the three cases, there are new health models inspired by primary care, and they do have as key characteristic, which is universal and free access to public services. This is stipulated in the three constitutions. Free and universal access to public services by the population that emphasize the promotion of health and prevention of diseases, and this promotion understood as action on social determining factors of health that do have an intercultural discipline or interdisciplinary focus. The different conceptions, how do we understand primary health care? In the three countries, there is no legislation stating explicit mention to primary health care. Perhaps Ecuador does. It's called primary renewed care as the basis. Bolivia, let's say the model is called family, community, and intercultural health, that is conceived as being a whole evolution process of primary health care services that takes the Almeida and the Montevideo of Pajo as sources of inspiration, but Bolivians, we believe that we have gone beyond that, and I think that is similar to the conception they have in Venezuela, where yes, primary health care is what integrated of the Almata as being a source, but also trying for the integrated care model should be a qualitative advancement from this perspective. How are we organized? First, let's talk about the states, and therefore the health systems of each one of the countries. Bolivia is a highly decentralized country, be it is the departments, which is a political division that we have, its municipalities, or even, let's say, an interesting characteristic, which is their originary people. So peasants have their very own autonomy or independence. Obviously, the health system follows this decentralization process. Ecuador is a country of high concentration of the different health systems, but with a low decentralization. Again, still there is, I can say, there's a strong influence of the ministry that delegates responsibilities but maintains its key responsibility in its hands. In Venezuela, actually is in the middle. During the 90s, Venezuela, 17 other 24 states were decentralized, but there is a policy for recentralization. For example, two of these states have already been re-centralized again within the national state system. Now, the three countries do have an organization according to different levels of cares with different complexity levels, first, second, and third level, exception made to Barla Adentro, which is an initiative, or Barrio Adentro in Venezuela, that more than anything else, we have, they recognize complementary networks in terms of complexity, also of a higher complexity and lower complexity, the first level of care, or be it the primary network, it is the door of entry for the system in the three countries. But the three countries still, they have free election. They can freely choose their service providers in practice. In the three countries, we can go to hospital, third level hospital actually, and care has to be provided mandatorily by their mechanisms, more in Ecuador, in Venezuela, or less in Bolivia, but there are mechanisms through which the patient is incentivized to go to his first level hospital. And this first level hospital is the closest hospital to his household, where there is a certain type of mechanism in place. In Venezuela, in Barrio Adentro specifically, actually, what we call this, which is dispensing, actually, that means, which is there's a relationship, the health team takes on a relationship of proximity and responsibility for this family. Because in general, here we're talking basically about families, not so much of individuals. And Bolivia has a newer system, more rurally based, but also we have this whole process in which a health team, actually is integrated to a community, understood as a family groups. Also, let's say the family records, which are very that are tools that are used in three cases, is the one that materializes this relationship, because an instrument where the information is collected on the family data and its determinants, the living conditions, understood as social determinant factors again, and indirectly on the community. Those are data collected on the community. Financing, and I'm going to make it faster. In general, those are national funds that come from general taxes, and in the three cases, come from hydrocarbon revenues, oil in Venezuela, Ecuador, gas, natural gas in Bolivia, that are the most important fiscal national commodities that are transferred to the regions, that are transferred to the second level of government, or third level, actually, in the three cases that might be the department, the province, and then the municipality, finally, that are where the services are actually their services that are financed through budgetary items. You see, there's financing together with on the budgetary basket or item. There are other types of payments, but basically those are marginally based. Bolivia still maintains elective insurance, and this is financed through a fixed percentage of taxes collected. They're transferred directly to the municipalities. Also, this is managed by the municipality itself, and the rest of the public financing, no, it's more comes is more in the hands of the department, which is the second level actually in terms of country territorial division of the country. Actually, there are no Venezuela and Ecuador actually don't have out-of-pocket expenditures. Bolivia still does, unfortunately. Those who are not covered by insurance, elective insurance, actually, it, and the people who are over 60 or children or pregnant women should pay for all services, or even in the in public hospitals. So also what is being subsidized of infrastructure and equipment are the different wages only. All the other operational costs come out of the pocket of the patient, which represents actually a greater barrier to free access, of course. This is another difference to be found, perhaps one of the most important ones to be found. In terms of availability of financial resources among the three countries, which is immense. $70 approximately is considered a per capita expenditure per annum in the public system in Bolivia, 332 in Ecuador, and 555 also in Venezuela. In here, I try to pay attention to Jose Manuel. Public expenditures in terms of total expenditures is in 44 is 40% in the three cases. Venezuela, I think that we have to take this data with certain cautious, because I guess that some items, budgetary items, are not included here. For example, Barrio Adentro, with its with the direct financing from the oil revenues is not included here, and these numbers could change somehow. But I think they provide us still with a general idea, which is very solid. Services in primary health care. Here, once again, as Gilberto did, I want to say that primary health care in the three countries is not a health system, it's a global strategy. It's not just a level, it's a global strategy. As of here, when I say primary health care, actually I'm saying first level of our care of first point of contact. So is more so each country might not be in agreement with me stating what is or not actually primary health care in each one of the countries. Let's see. We have public hospitals and social security hospitals in three countries. Ecuador and Venezuela, there has been a segmentation from the viewpoint of the public because access is universal regardless of the or who is a manager of or the owner, be it is a health insurance bank or not, or institution. In Bolivia, it is segmented in Bolivia except for the beneficiaries of public insurance. Only those insured can go to their insurer. Ecuador has three institutions, insurance institutions: the Ecuadorian institution, the police and the armed forces, with the peasant insurance, which is part of the Ecuadorian Institute, but it has very own specificities. Venezuela has a different situation in which the public, big state-owned corporations do have their very own institutions, but this comes from financing. Actually, the hospitals are open to all. Bolivia still has 18 insurers. Also, cajas, we are called cajas, also health cajas, is little cajas, which are financial institutions. There are big differences in terms of their size. Still, segmentation exists in some senses. Venezuela and Ecuador is in BC, the access to services are almost identical for all, with an interesting exception of Ecuador, which is insured. Policemen are the only ones that have co-payment. This is a demand from the legislation. For the rest, also the rest is free of charge. This is just an anecdote. Let's go now to rush somehow because we're running out of time. Let's say the private care is important in the three countries, much more in Ecuador, where there are still NGOs that have a good chunk of the segment, but are part also of what we call a public network, because they're strongly regulated and get financing, also public financing. And in general, also we have actually in Ecuador have started more or less recently with a scheduled system that might be personal or on the phone to organize this type of this care. Otherwise, it's a come first serve basis. In Bolivia, we have 1.3 actually actually consultations, 1.8 in Bolivia, 3.8, out of which Barrio Adentro has 2.9% of actually doctors' offices consultations. And we are not going to read this. I just want to show you very swiftly the size and the complexity of the organization of the different types of hospital and health units. Also, what we are considering as being primary care, from the popular doctor's office, also different rehabilitation rooms, Barrio Adentro in Venezuela, and the other countries with more or less the traditional structure. We have the health post or the health unit, which is very basic in Bolivia, represents half of the first level, which is actually they only has actually a nurse or an orderly. Still, we have this situation in Ecuador and also in Venezuela. But in terms of the primary hospital can have from a doctor, a nurse, and an orderly, and also with certain equipment to more sophisticated levels in which there is surgeries, actually emergency or outpatient surgeries that are being performed, for example, in certain areas of Venezuela. The three countries, more in Ecuador, a little less in Bolivia, they're mobile teams. There's mobile care for populations of difficult access. There can be ambulances on wheels, attention, or boats run through rivers, and specifically in Bolivia, there is a very interesting program that we're going to learn about this afternoon, which is Mi Salud. There's a brigades, don't necessarily go to your geographically more remote areas, but they try to care for traditionally excluded populations, also with a strategy of actually of household visits. The three countries, promotional services, preventive services, and healing services should be provided by the same team. In Barrio Adentro, in Venezuela, rehabilitation, and also in Bolivia, nutrition has specialized structures.
This is a vertical program. And one of the questions in Bolivia is as the new birth have to be attended in all the levels. This is the more basic. And in Venezuela, they try to arrange it at more complex levels and specialized levels. Ecuador and Venezuela have the attention for curing in the house of the patient, not in Bolivia. It depends on the characteristics of the rural areas. In the urban areas, there are no visits to the houses of the patients. Yes, they have some filters in terms of the physicians of primary attention, and there are some systems and tools of reference and counter-reference in the three countries that work partially, on a partial basis. Usually the reference works very well in the first level up, and the counter-reference is much less because in the three countries and more in Venezuela, the level of at the hospital above primary health care has not received the reforms and the changes that have been established. There are some queues. People have to wait in specialized attention in the three cases. More in Bolivia, of course, and less in Venezuela and Ecuador with a similar situation, intermediate situation. Here, one general idea on how the resources, human resources, distribution of human resources. Ecuador and Venezuela try to have a specialist in primary attention in charge of the basic offices, not in Bolivia. They are still having the general physician as the primary attention. And they receive a salary In Ecuador, also, they have temporary temporary contracts. In the case of emergency, they are trying to regularize this contract, and the salaries are higher, taking into consideration the decentralization. Then you have an agreement with the ministry, and then the districts and the hospitality. They have their own stuff. It is very difficult to manage all this in Bolivia. Here you may see here in the three countries there are strategies for qualification of human resources for primary attentions which are important. I have to conclude. Well, I'll try to go faster. I'll go faster. Venezuela has the medical residency in family and community health, which is nothing to be the provider of services, but to be an agent that promotes and transforms a social transformation. Ecuador and Venezuela, they have strategies to qualify specialists, and in a very short space of time, so all the clinics are governed or managed by physicians or clinics. And there is something very important because we have community agents or technicians in primary attention in Venezuela, Ecuador. They are being qualified as the fundamental members of the team. We will see now, refer now to inequalities, rural population, the poor, they are excluded with differences, important differences. Intersectoriality is based in a paradigm of the three countries, which is to live well, and from that idea they are guided through intersectoriality with little progress in the three countries. Bolivia has malnutrition with a program that has been working satisfactorily, and in the other two countries we find progress, timid progress, except in the case of intersectoriality, Venezuela with the social assistance, and the three countries has great progress in this. The social involvement is mandatory in the three countries. Still, they are having, it is not well implemented. These are new processes with different degrees of development, and I will stop here. And also, there are two viewpoints. We have just one view, and the respect to the other cultures as the articulation with traditional medicine. These are processes, initial processes. And then the final consideration, and these are countries in transition. They have a clear vision that to break with the reforms of the 90s, with great progress in Venezuela, Ecuador, universal gratuity, strengthening PHC, but also with a lot of challenges. I mean, the old structures, strong opposition, and the reforms have been superseding each other, and this has increased fragmentation of the system. But we have a great hope, and we see that in the providers and in the population altogether, and in this humble consultant that is visiting you today. Thank you very much. Thank you very much, Herland. And now we have we will call to the panel to present the experience of Chile, Peru, and Colombia, Román Vega, which is a surgeon, doctor in administration and health policies from the University of in England. He is a lecturer at the Pontificia Universidad Javeriana in postgraduate courses in public health, has a master's degree in social policy and doctorate in human and social sciences in Bogota. And also I will call Naydú Acosta, Mr. Román Vega will do the presentation. Naydú Acosta, she's a medical doctor and a doctor and magister in health administration and lecturer in public health in Santander University with 18 years experience in the implementation of research projects and development projects in the area of services and health systems, mainly the evaluation, implementation, and management of PHC. Also a well consultant from Suriname. She did the case studies. Hedwig, which is a consultant in public health. She's a doctor, physician, Michigan University. She's a consultant also in the area of public health with experience in the institutional capacity and strengthening innovation in organizations, health programs in the community, development and organization of health systems, qualification of human resources, and she comes from Suriname. Now we start with Román Vega for his 20-minute presentation. Very well, very quickly. 3 countries whose systems, health systems, have as similar characteristics. They are systems, insurance systems. They are the result. In Chile was the first reform. Then we had Colombia in South America with this model. And I believe that Peru is the 3rd country that is going to reform insurance, their insurance basis. The structures differ. In Chile, we have a two-way system with public insurance, which is CONASA, and a national network of health services, and also private insurance, which are the ISAPRES. In Colombia, there is insurance also. It's a mixed public-private. It's a public-private mix of insurance entities and provider of services. They are unified and divided according to contribution. That means a contribution and a subsidy. In Peru, we have a system, an insurance system, which is a social health insurance with semi-contribution system and a subsidized system. Is the Bismarckian system, and there are other systems in sectors of less income in the population. Peru also has a private subsector, which is not integrated to the health systems, and the 3 of them have special regimes, public funds, but in Colombia they also have in some sectors of the population. Financing of this system or funding is made by salary contributions, but also with taxes for those sectors that cannot pay. As a characteristic, they also have plans for health plans. For example, insurance and private interests within them. They manage health plans and individual services, but also health public plans and complementary plans. The choice according to the payment capacity of people. In the case of Chile, there is a universal plan, and the Ministry of FONASA, there are voluntary plans also, which are the ISAPRES, and a public health plan. In Colombia, there is a mandatory plan, subsidized, and complementary plans too, according to the payment capacity of the individual public plans. These public health plans include collective actions. So there is a separation, a division among what we call private assets and public assets, and that is why the organization is split. Coverage in these systems, according to some surveys, in Chile is 93%, 74% for NASA, 70% is SAPRA, 2% armed forces, Colombia 88%, 41% in general, 52.7% subsidized regime, 47.6% contribution, non-undercover or non-covered, 57%. There are more recent data in Colombia. These are the Quality Life survey for 2010. General coverage in Peru, 62%. In the social security system, 31%. 24%. In the integrated health system, 31%. In health, 24%. And 7% in private ones. All of them promote strategies for primary health care from the public sector. The general focus refers to PHC with the tradition of Almata and renewed medical care according to the PAHO in 2005 and 2007. There are some specific characteristics. The Chilean aspect is district by district. In Colombian, we cannot say how it is. It's really heterogeneous, depending if the PHC do it with other insurance companies which use PHC as a strategy of competition, or through the territorial entities in charge of health, that they work with public health plans, and they develop strategies for attention to the public or the indigenous populations, which in the framework of the structure of the health system, they develop models for attention to the public in the area of health, similar to Peru also. From the viewpoint of competition of governmental spheres, there is an orientation of policies of primary health care from the ministries with more qualifications in terms of formalization of policies in the Chilean case, where we have really the role of the Ministry of Health less strong in Colombia and important in the regulation, technical regulation in the case of Peru.
There is important role to be played by territorial authorities, in other words, of the different municipalities, provinces, departments, in terms of management, administration of the of primary care systems, and of course, operators are generally different institutions that provide services. In the case of Colombia, these institutions depend on the EPSs and generally are privately owned, and in the local health authorities are public hospitals. In the case of Chile, they are actually public institutions, and in the case of Peru, are also public institutions. I'm not talking about the rest of the network just to characterize these operations. There are specific experimentations in Chile by the Catholic University that definitely our colleagues from Chile will talk about this later. From the viewpoint of financing, in general terms, there is financing defined for primary health purposes. From the Ministry of Health in Chile, these service providers are paid per capita, a communal and basal per capita. The communal per capita makes adjustment per age, per poverty rate. There's a certain notion of equality within the conception of the Chilean communal per capita ratio. There are additional funds, including municipalities, that supplement, according to the needs, the total financing process of primary care services. In the case of Colombia, the sources are different. In general, let's say a big one is the per capita payment unit, which is what's paid by the affiliates. In this, they per capita finances primary health care services. The problem that Colombia has is they have different sources defined in legislation for primary care, but there is no competition, which is the separation that can be found between what is private and public are maintained in terms of financing possibilities. As in the case of Peru, we do have ordinary resources at national level and collected resources by service providers from the insurers that insured people that buy these services. In general, there are different types of payments that I would like to show you. Payments to the provider per capita or prospective payments per services in Chile. And also the same thing in Colombia, their per capita payments is a for promotion and prevention system of global fixed payments per events. And something similar can be found in the case of Peru, for when we can find better the uh, the traditional budgetary model assigned to service providers. Now, in terms of co-payments, as I'm going to be stressing in my presentation, Chile there's no co-payments for primary healthcare services. So this access is completely free of charge in primary healthcare hospitals. In Colombia, there is no co-payment except for the promotion and prevention and also communicable diseases emergencies. Peru, there's a payment out of pocket in terms of financing of primary healthcare. Also, we can see that there is out of pocket payment beyond public finances. Well, there is a general characteristic in the systems. Also, in the insured systems, there are specific policies in primary health care. In Chile, there family plans. Also, there are programs that come from Pinochet. I remember that guarantees the AUBE actually plan that has 89 prioritized diseases. Our Chilean colleagues will talk about this later. And there are other plans or plans like Chile Grows With You. In Chile, there are two big plans. The mandatory health plan that has primary health care services, healing services, and promotion and prevention. And also we have the public health plan that is constructed as of the different municipalities in a participatory manner. And so in Peru, there are packages of integrated care for the family and integrated care for the community. So we have a characteristic of the insurance system, which is this need to define the services that are packaged individually or collectively. These service providers basically in Chile are of public nature. There are some affiliates also. They can choose private service providers paying a bonus. In the case of Colombia, the service providers are of the first level, also public and or private too, depending on if they depend on the insurers or the territorial health bodies. And in the case of Peru, actually they are public service providers. In terms of there is sectorization of activities. In general, sectorization actually happens in Chile. In Colombia, there's only sectorization where some health teams may do sectorization. There is a great difference, inequality in terms of integration of the teams by regions of the country, depending on the resources available to each region and depending on the design according to the influence exerted by local powers of the different municipalities and departments. Also, there is sectorization in the case of Peru, but generally speaking, the population is assigned to teams or different institutions, like the case of Chile. In the case of Colombia, there might be, if there are teams, there might be allocation in Medellin, in Bogota, but this is not generally used. And something which is very interesting to note, we cannot assign population clearly in terms of territorialization. Also, these have affiliates in a very extended territorial base. Therefore, there are no districts in just primary healthcare services. In the case of Peru, their user register according to the domicile. In the case of Chile, there's an organization that are basic teams, and their basic teams plus a complement. The complement beyond the nurse, the doctor, and a technician in health includes other health professionals. For example, we do have actually a midwife is very important to have them in Chile. There might be in Chile also psychologists and other professionals. This is the Chile actually has different basic teams and has teams with supplements, which are teams that are multi-professional, not multi-professionals in terms of the medical professionals, classic medical professionals, but multi-professionals in terms of including psychologies and other professions related to the health area. In the case of Colombia, when the when there is primary health care in the public sector, in the case of Bogota, let's imagine there are basic teams, but also besides this, just like it happens in Chile, per locality, we can find different complements, extended teams that are providing support and include other types of professions, just like we see in Chile. But this doesn't happen in the whole country. And in the case of primary health care, basically are general GPs, nurses, and they have other professions like pediatrics, gynecologists, through which they provide primary health care. Actually, they have a strategy of a program in Colombia. Not all of them they have programs, but the basic teams in Peru also are made up by obstetricians and nurses. We have uh, we have different cases in Peru. We have 5,000 families in the case of Chile, up to 5,000 families in the case of Chile. He says once again, but not in Colombia. Colombia, there is a diversity, perhaps there might be or not. In the case of Bogota, here there are basic teams of family health, of public health, but not in this is not applicable to the whole country. In terms of integrated care, there is very strong planning from the Ministry of Health in Chile. This is a process in Colombia. We have actually they are regulating this piece of legislation in 2011. There's planning in the case of Peru. We see a shot of Peru, an image of Peru. We see the actually primary health care in every country is the basis for integration of all services. They define that the service network is an integrated network based on primary health care in health care. This is what can be seen generally actually in these countries. It's clear cut in Chile. This is a family health center in Chile. With regards to integration and coordination of services, we should mention that generally speaking, we see that the health teams or the primary health care centers are a door of entry, and the doctors actually are the filter in the health systems. There are attributes that are clearly defined of primary health systems, longitudinality, coordination, and so forth. But in general, the countries have been designing a series of instruments in order to facilitate coordination of primary health care. I'm not going to detail them, but this is the trend that can be found in clear-cut examples. Also, use of different information technologies, actually medical records to improve the processes in terms of coordination, and of course, their waiting lists. These waiting lists are basically for the case of specialties, medical specialties in Chile and in Colombia. Also, we can find in Colombia that a primary healthcare system has 2 or 3 days waiting list for GP, but has 3 months or more waiting list for care in other medical specialties. There is a common rule to be found in the 3 countries' labor force. Now, it's important to say 3 things that I think that are key in terms of labor force in the 3 countries. Chile, there is more regulation in terms of labor relations than one can be found in Colombia or in Peru. In Chile, there is statute in primary health care that regulates the relationship of the workers. I cannot explain it because we're running out of time. Colombia has a deregulation policy. In Peru, half of the population has fixed contracts, but the other half has as undefined term contracts, which explains that there is a strong influence by deregulation in terms of labor relations. The consequence of it all is that in the case of Colombia, the enormous labor instability of workers, most of the health workers, the precarious salaries, and of course this has exerted a clear influence in terms of the full of compliance. We cannot ensure actually permanence between the provider and the patient when there's no job stability of the doctor, of the nurse. Let's say the deregulation, labor deregulation, which is a neoliberal policy, goes against the attributes of primary health care systems. There are training programs, education programs in the country, yes, but stronger can be found in Chile, less strong in Colombia, and even weaker in Peru. There are designing guidelines that are being developed They will be mentioned later. Remunerations is made through wages, but there are other remuneration ways or system through products, through achieved goals among the different countries. The doctor's rate actually in general actually is lagging behind in Chile and in Colombia and also in Peru. In Chile, the problem is very severe since they they have a family health program that has 629 doctors, so 50% of which used to work in the private sector, as far as I know. And the deficit in Colombia is very grave. One of the key problems that we have to discuss amongst ourselves is the whole issue of the labor force in terms of the amount, because primary health care is intensive in human resources. In terms of the inequalities, well, there are great inequalities. I'm not going to give the numbers, but inequalities are horrible in the case of Chile. Inequalities between FONASA in terms of financing, per capita financing, in ISAPRES is of 22 to 1 almost. Then those are serious problems. Inequalities in terms of distribution per regions and municipalities, per rich, affluent sectors and poor sectors in terms of health resources in general, not only resources, human resources, but also infrastructure, equipment of infrastructure, and so forth. And well, in terms of access, the same thing goes. It's a general rule in terms of inequalities. It can be found everywhere. The most affluent and the richest cities have better access than those that are poorer, as we see. In terms of social participation, there is a trend. All countries in Latin America talk about social participation. The problem lies in the fact that stronger in some countries and weaker in others. It will depend on the sense of democracy in each country, but all have constitutional standards, they have regulation, have space for participation. They do have different community-based organizations that promote participation. We could understand primary health care in Latin America without this important component of community participation, citizen and social participation. I think this is something that makes us be very relevant. And another key element in all of this panorama in terms of care is something that we cannot find in Europe. All models do have community health agents, perhaps. The only thing that differentiates them, that in some countries they are voluntary. In Chile, in other countries, they're paid for. They are health community agents that are part of the health system. They're paid for, and they have a program to implement depending on the health system of each country. Since I'm out of time, the last thing is intersectorial action can be found at national level and also at local level through the municipalities. And the very last thing, one of the key messages I would like to leave to you.
The question of the primary attention is interculturalities, or what we Latin Americans mean by that. We refer to that because we have indigenous populations that were conquered by the Spaniards, and these indigenous population, they claim the right to their ideas on health and their medical practices, which is different in this country. They have beautiful experiences of interculturality. The thing is that perhaps there is a more sensitiveness of the governments to these claims of the indigenous people. So this is something that is being developed. We have to carry out a study specific of the original peoples of Latin America and the forms of interculture that are being developed in the framework of primary attention of health. We hope that the universal countries will approve this. This is like a symbol of interculturality in an indigenous hospital. But in Chile, there are different centers, mixture of the Western model and the traditional model of the countries. In general, what do they claim? What do the indigenous people claim? The right to have their own systems. And as Colombia says, but we do not deny the right to get the benefits of Western medicine. But please don't confuse us. We are different. We are different logics, different ways of seeing health, and different practices. This is beautiful to see. In the case of Colombia, how the indigenous peoples, with statistics, with names of their diseases, the same as the governor, they discuss the epidemiological profiles, risk factors, determinants of health. Two languages interacting at the same time. Do you understand me? Indigenous people have to look for that to happen. Thank you very much. Thank you very much, Roman, for your efforts. We have a 5-minute break in order to stand up, take the phones for the translation. She's going to speak English. This is a 5-minute coffee break, just for a little shake. Okay.
My presentation in English, and I hope you can follow. I'm very pleased to be here for several reasons. One, because I'm from Suriname, and Suriname is very much isolated from the region. It's easier for us to go to Holland than in the region, even in the Caribbean region. And secondly, I have worked as the health systems advisor for a couple of years in Guyana, so I was very happy to be able to go back and see what happened in the past period. So thank you so much, and I have learned already a lot in the 1.5 day. Okay, I'm gonna, yesterday many people mentioned that they don't know nothing from Suriname and Guyana. So I'm in the position, and also as last speaker, to give you a little bit of background and give some examples of good examples that you might not have heard of. And I'm going to limit the general information that you probably will see later. Okay, so Guyana and Suriname, they are at the north coast. If you can see them very small there. And there are many similarities, but also many differences. Definitely there's this shared geography, which is one of the major challenges actually in healthcare. Large rivers, the Amazon, very difficult to reach, some places only by air. Also a shared colonial background, because Guyana has been shortly under Dutch rule, and Suriname also has been shortly under English rule, and Suriname ended up with the Dutch, and Guyana with the UK with the English. And we will see that that also has influenced the development of the health system. There are also some similarities of the population, a very small size population. In the case of Guyana, I will show that later, and also a very low population density. If you look at the composition of the population, it's very diverse, and Guyana and Suriname, together with Trinidad, are the only ones who have a large population, but actually that's the biggest population group, descendants from India. And Suriname is a little bit different in that regard, but I will go to that. There's also a very specific geographic distribution, which is similar, because the majority of people live in a very small, at the coastal belt, and the back of the country is almost empty. That is very similar. And the ethnic composition, I said something about that. But there are also marked differences. Suriname, I think, has a very unique ethnic mix with a population also from Java, Indonesia, which is the third population group in size. And there's no other country there in our region with that. Also a very significant Maroon population, who the runaways in slavery time, who settled themselves very deep in the Amazon region, and who actually kept also their culture very much. So if you're in Suriname, you can drive and you come, you feel like, am I in India? And you drive and you feel like, am I in Indonesia? Am I in Africa? That's it. So that is different. Guyana also is considerably decentralized, has local government, and Suriname has not, is in the process actually of establishing local governance, but that goes very slow. Also political, if you look at political development as independent state, there are many differences. Guyana has more socialism in history, and was also more earlier independent, was one of the founders of the Caribbean community, while Suriname joined much later and is actually very young independent state since '75. And of course, that influenced the health system very much. So we have very different health systems and very different governance of the health system. So very short then, the population. Yesterday, the speaker about Costa Rica mentioned we have a small population of 4 million, and I said to my colleagues and my friends from Guyana, oh, what will I say tomorrow? Because our populations are less than 1 million. In Guyana, it's a little bit less than 800,000, and in Suriname, it's a little bit more than 500,000, so to say. The population in the coastal area in Guyana is, both countries are about 85%. The difference is that Guyana has a much bigger rural population than Suriname. Urban population in Guyana is 28%, in Suriname it's 67%, and that's mostly concentrated in one city, the capital only. The rural coastal area in Guyana is 62% is considerable, and in Suriname it's 20%. And then we have the hinterland, with in Guyana a little bit less than 10% populated, and in Suriname a little bit more than 10% populated. So Guyana and Suriname are in the top 10, least populated, lowest population density in the world, and that is a major challenge. Both countries with population density per square kilometer in Guyana is about 4, and in Suriname about 3. And that is national level. If you look at the interior, it's much later. Okay. It's for me a little bit difficult to talk faster. Okay, anyhow. Another thing that I think is important is Guyana is a very much migrating country. It has a very high immigration rate. Okay. So if we look at, I'm going to skip to the health indicators, but the primary healthcare facilities, I have here the figures up. For Guyana, we will see there are 148 in the hinterland, which is considerable, and I will say something about that. Human resources is the major issue. Total health expenditure reported by the countries is much higher than what the estimate is of the World Bank, so I've put both up so that we can see. This gives a bit idea about the population distribution of physicians in Suriname. And then if we, to talk about the concept of the primary healthcare situation, it's important to say that there are actually both countries are in a very, really a transition phase. In Guyana, the shortage of workers is the biggest problem, is an immense problem in Guyana for healthcare. But now they have the large numbers of Cuban-trained physicians are returning because Guyana had more than 500 students in medical faculty in Havana, so that's a big difference. And in Suriname is in a very special stage now because it's introducing a national basic case insurance system, which will be change the services dramatically. And in addition, in the hinterland, we have really a transnational context now due to the gold mining industry with lots of people from Brazil and other nationalities. So that's the situation. So now we looked at the primary healthcare concept, and we saw that in if you review the national health documents, that Guyana has really a comprehensive view, but it is often referred to as primary level of care. But it is defined as the foundation of the health system since Alma-Ata, and it has remained as such. It survived as such, that concept. In Suriname, we saw that after Alma-Ata, there was a comprehensive view. It was defined very comprehensive as a strategy, but then we got a decline, and it is now really replaced by first-line care, the concept. Recently, there's a start of a renewal process where there is a call to go back to the comprehensive view. Constitution and legal documents, Guyana, constitutional, there is a right to free medical care for everybody, included in the Constitution, so there's no payment in the public system at all. And in Suriname, right to health is also included in the Constitution. This is all about in the around the 80s after independence that it was included in both countries. So if we look at the health service delivery system, we see that Guyana has a public system. Of course, it has a private sector, but the public system is organized in a way that it guarantees services according a public package, and lots of things are legally defined and protected. It has levels of care, beginning at the health post, staff with a community health worker, up to the tertiary hospitals. And the primary health care services and facilities are integrated in, you can say it's a district health system that they have with local governance responsible for the services. The Minister of Health is also in the process of devolving authority to regional health authorities, because local government is, of course, are elected people, so there's a lot of democracy, but the managing the services is a bit difficult for them. So they have established already one in one of the regions. Suriname is different, completely different, because it has a very much fragmented system, really based on different payment schemes defined by either your occupation or your economic status, etc., or your geographic location. So it's very much fragmented, very difficult to coordinate. And the Minister of Health is not any longer a direct provider of primary health care services as it was in the past. It has now autonomous health institution, and has a contract and is funding the primary health care services. Okay, so I mentioned something about the human resources is really the most critical challenge. Distribution imbalances as well. In the case of Guyana, 70% of the physicians are located in the capital. And then, of course, we have the unique challenge of geography, uneven population distribution, very small villages along rivers of sometimes 500 people, etc. Actually, about 10% of the population lives in almost 90% of the land mass. That's with rivers, etc. So I was actually asked also to look for some innovative examples of what. So I want to go very short and quickly in this. This is from Guyana, where even before Alma-Ata, a start was made to reach people in the remote areas. And what Guyana did was really looking for introducing other than physicians and nurses, the conventional professions, for primary health care. And what they did was introducing mid-level workers with multi-purpose skills, because it's very difficult in remote areas to have administrative personnel, this or that. You need all-round people. That's the only way. So what they did was they introduced the medics, which is a practitioner that is totally backed by legislation, etc. And short after that, that was in 1977, they introduced the community health workers, first as a short-trained worker selected by the community, so as a volunteer, got incentives from the community. And now it's completely incorporated in the official public service structure. It's the lowest level, lowest healthcare worker in the system. The medics is very well defined. It is absolutely the worker that represents primary healthcare because it is defined in the act, so legally, as a community-oriented health worker geared to provide a reasonable level of care, works primarily in remote areas, and performs certain specific tasks that are normally performed by doctors. It's very difficult to keep doctors there, not only because they want to stay in the capital, but they probably might lose skills or what, because it's a very low population density. So I think really the strengths are the training, the legislation, and the duties are very much defined in the Act. So different from what we heard yesterday, where the physician was central in the case of Guyana, especially for the backland, the hinterlands, it's another team. Officially, they say, yes, we need a physician, etc. Maybe 1/3 of the time, the physician is doing 3-4 clinics, but then it's still very difficult to transport because some need to fly to another place, etc. And the community health worker as well, 6 months training, and the health posts are very good constructions. In the past, it was from home or what, and they have a set of skills and specific things, more preventive services, but they do the immunization, they do lots of things. Okay, there are some new developments. I'm gonna, because I need to rush. In this thing of the medics, because the medics is something from Guyana that exists 30 years, and they had evaluations around 30 years commemoration. And what they saw is the medics was recruited from the nursing pool, that they were depleting the nursing pool. And what they did is that they decided to do a new pathway where, and that is where you can see the influence actually of the state, which is different from Suriname in Guyana, because Guyana had very much infested, their backland is indigenous populations only. In Suriname, it's also Maroon, and that's actually a bigger population group. But they invested a lot in education on purpose, and now they have lots of people who want to work and can do jobs. And so what they decided is to recruit, make it a 4-year program, and recruit directly from the underserved areas. Another example that I will give, and I need to thank Román because he introduced it already, just now, which I think, because that has to do with the interculturality, and is one example from Suriname that I want to like to mention, and that has to do with a new idea of closing very good partnerships with traditional healers in Suriname. And it's very important because the Amazon region is almost like a pharmacy, the lab of the pharmacy. It has lots of therapeutic plants, and we are now at risk of losing the knowledge. In the very south, we have trio populations, and they have really a very good formal system, formal ethnomedicine system, so to say, and very rich knowledge. So what happened is that the medical mission, together with Conservation International and the shamans of those trio villages, started actually a pilot in 2 of the villages where they introduced, where they built, actually constructed a health post for the shamans, actually close to the formal clinic, and they had workshops where they had joint learning experiences and sharing, etc., with very good results, because both the formal and the others were adapting the practices. referral and counter referrals are doing. And also was discovered that the treatment of leishmaniasis, which is endemic in Suriname, in the interior, that the shamans have a very more effective treatment from traditional medicine and at lower costs. So this was a very good experience, and therefore it's going to be scaled up to the Maroon villages, because the Maroon villages with people from African descendants are very good in bone setting. And so this is one of those things. I know that I have not covered all the things. That was not very clear because I was all the time in Spanish things, but just for a couple of things that I have not put in the slides, but and there's no co-payment, those things that you're interested, no co-payment at all in Guyana. Everything, even if you walk in, they can't charge you because there's no system. That happened to me. So it's completely free, but of course it's very much under pressure because of the human resource, the immigration. It is an English-speaking country. There's a big market in Canada and in the United States. They come and recruit nurses even before they are graduated. They hold they put up booths, etc. So, but that is the system. It's completely financed. There are collaborations with the public sector for services that they cannot provide in the public system, such as dialysis. And it's very much by the state-driven. In Suriname, there's also no co-payment for people who fall in the social security system. They only pay very little money when they fill their prescription. So just to conclude quickly is that we see that the context is extremely important when looking for strategies, because what are you doing? You can say, okay, this is the team that we want to have. Are you going to put those people in? You need to fly them in to villages of 500,000 people, etc. There are many shared challenges, and that's the thing that we share the most, but different healthcare system. And Suriname has the challenge because the system is very fragmented, very difficult to coordinate. And what we see in primary healthcare, the development, the renewal, etc., that in Suriname the initiatives are more at the subnational level. For my colleagues who are here, their organizations who provide services, and it's also it's the fight that it's not a unified system, not at all. In Guyana, the initiatives are from the state, which makes it easier to put the backing, the policy, and the legal backing. And I think that's what I would like to say, because only the rapid changes where I think it's very interesting to follow what's going to happen with Suriname now that they are introducing a national system, which of course is good because it will make access more equal, but on the other hand, it has also a risk because they want to put, you lose your territorial analysis and planning because everybody can choose the doctor free of wherever they are, and that is a big challenge. Okay, so the rest to say, because we are here in Brazil and we have an interior now, which is completely different, with lots of Brazilians in gold mining and other people. And there is such, we are actually at a point that we really need to see how do we, everybody has the right to health. It doesn't matter if you're there with no documents or what. But the question is, who's going to pay, of course, and it's expensive care because it's in very difficult places. So I would like to conclude with this, and thank you.
Thank you very much, Hedwig, for your very interesting explanation about Suriname and Guyana.